but we will be done. So you are 2 hours down, 46 to go. One of the things, remember we talked about yesterday, we're going to try to make sure you know a little bit about pediatrics as well as pediatric medicine. So just want to warm up slow with the beginning of some lectures. So just want to make sure you have the basics. So, in the movie Frozen, what is the reindeer's name? Sven. Yes. Things like that. It's part of pediatrics as well. Second part is I usually go back over the lectures. We start with just kind of a warm-up from yesterday to get your heads back in the pediatric game. For a while, people were like, what's on the sticky notes? It was like, whatever I remembered from yesterday. So this is not this is what's on the test, only study the sticky notes. This is just kind of a review from yesterday to warm up, okay? So, when you are thinking about storch infections, what does the S stand for? Syphilis. Yes. At what heart rate do you start chest compressions for a neonate in resuscitation? 60. At what number do you get 2 points on your APGAR? Greater than 100. Greater than 100, yep. How do neonates respond to hypoxia? Perfect. What, for your standard care, what does the erythromycin eye ointment treat or prevent? Gonococcal conjunctivitis. Yep. If you're concerned that you have a congenital heart defect and you either have more than 3 difference or less than 95 on your heart screen, what would be your follow-up imaging? Echocardiogram. Yep. Oh, we haven't gotten there yet. What did the quad screen assess for? Yep. And why are those the 3 trisomies? Haploid life. What's besides the trisomies? What's the other one? Yep, alpha fetoprotein, and that's looking for? Correct. What does APGAR stand for? Activity? Respiration. Good. Okay. And then to jump back in where we were, just so we are warmed up right for that spot, as I get to the correct place. For caput succedaneum, is that one the scary one or the safe one? Safe one. Yep, which is the scary one? So yep. Okay, so where we were yesterday, we were talking about the baby being born, your role as that provider. We were starting from a head-to-toe exam, so we had just started on the head. So we were jumping back into the head. So, things that can go wrong. You could have a too small of a head. We talked about if the sutures were fused, that would mean that you have craniosynostosis. But what about if your head is too big? If you have macrocephaly? So you could have a couple of different types. You could have just a baby with a big head, and a lot of times that is benign familial, right? If you look at mom, you look at dad, and they both have big heads, and the baby has a big head, well, that makes sense, right? If you look at mom and dad, they're very proportionate, and you have a baby that not just a big proportionate head, but looks more like the alien structure, a little bit like this picture, where the face looks normal, but you can tell that the head shape is extended and large. That is what you are more concerned, that there is some sort of excess pressure. So excess hydrocephalus, if there's fluid, or an excess where there is mass, there's some type of tumor. You can have that be communicating with the rest of the cerebral spinal fluid or non-communicating. If you are non-communicating, you're more likely obstructed because there's not that free flow, and that's going to increase your ICP, or your intracranial pressure. So that would be a little bit more of a concerning one. If you have that hydrocephalus, or you have something else that's going on with there, one of the things that you're going to be looking for is how are we going to work this up? We need to get some type of imaging. What type of imaging is our go-to for pediatrics? Ultrasound. Ultrasound. Where are you going to ultrasound? Yeah, what is that? What's the soft spot called? Anterior fontanelle. Yes. So you are going to have an ultrasound of that anterior fontanelle. The way you can decide, you're not just being like, well, I think that's a big head, I think we should ultrasound that. It is if your measurement is 2 standard deviations away from the mean. That is what that means there. So you can, on those charts, and we'll look at different types of growth charts if you are more than 2, and I'll explain what all of that means. But for now, know that 2 standard deviations above the mean is what a lot of things raise our red flags for. What are some of those red flags? Well, for macrocephaly, certainly if you have a head that looked like that, so if it looks kind of alien-like, it looked out of proportion large there, it was more than 2 standard deviations, or you had that bulging. Right? If you have the 2 plates that you're feeling and suddenly there's a big bulge there, not normal. If the infant is not responding appropriately, this would be not spit up, this would not be just I'm regular crying, this would be I am unable to be consoled, I'm irritable, I am vomiting everything in large quantities to the point that I'm not gaining weight. You're spastic, so remember infants, if you've ever held an infant, they're kind of floppy a little bit, so if you are spastic, if you are seeing papilledema, and then certainly if you are seeing sun setting, a gaze where the eyes look like they are going below and you're seeing more of the white of the sclera, it's a concern for increased pressure. Yes, sir?
Is spasticity like they're kicking, or is that more like a seizure activity?
You could see either, so it depends on how much pressure there is, but a lot of times they will just be real tense and stay tensed. But you could certainly have something that mimics, it's not necessarily a seizure, but it is from that pressure that is putting pressure on the brain. So comes in all shapes and sizes. So yes, you guys already had that. So if the soft spot is open, and typically under 6 months, everybody is going to have an open soft spot, open anterior fontanelle. So you can do your ultrasound of that skull at any time, as long as you have about 2 centimeters, enough for that probe to be able to get in and look at the ventricles of the brain. If it's closed, you can't do an ultrasound anymore, shucks, that's when we have to go to some other imaging. So a lot of times we'll do a head CT at some children's hospitals, they'll do fast MRIs. But for your purposes, your next evaluation after ultrasound would be a non-contrast CT. If it's normal, and the child is growing and developing normal, and everybody in the family has a big head, we can, after that normal workup, we can chalk that up to benign macrocrania. That would be familial most of the time. If it's not normal, you have the ventricles that are gigantic, you have intracranial pressure, you have papilledema, you have any of those other things, after you get that imaging, that would be an indication to send them over to neurosurgery for a definitive type of surgical treatment. Okay, so that takes us down from the head down into the eyes. So the eyes are super interesting, and I love eye stuff, so eyes just get me. So the red reflex is going to be exactly what you think that it is. If you've ever seen old pictures or any kind of pictures where there's red eye, the red eye is the red reflex. That's all you're looking at. You're seeing there's a translucency from the back of the retina that you are able to reflect. So it's that reflex. So if you don't see that red eye looking back when you shine a light directly in it, you know that something is impeding that translucency there, that transparency. So it's going to tell you that there's something in the way. So that something could be a tumor. That something could be an infantile cataract. That something can be looking in very different ways, shapes, or forms. And it's usually going to come back instead of a red reflex, it's going to be a white reflex. And a white reflex should make you pucker a little bit and assume that it is a retinoblastoma tumor until otherwise confirmed that it is not. The reason you need to think that is because if it is a retinoblastoma, that is a very, very aggressive ocular tumor and often will spread to the other eye and will often lose both eyes. Right? So this is a potential that this child could and will likely go blind and have just a very, very aggressive tumor. So if you see a white reflex, until otherwise proven, it is a retinoblastoma, and that is one where you get on the phone and say, "Hi, ophthalmology, would you like to see them now or in 20 minutes?" Right? Those are your options, pretty much. The other option is that you could see retinopathy of prematurity. Now, in medicine, and especially in pediatrics, the diagnosis is going to be important because there's a lot of things in the name. If you have retinopathy of prematurity, you need 2 things. What are those 2 things? Prematurity and retinopathy, okay? So that sounds ridiculous, but if the question stem says a term infant was born, it by definition cannot be retinopathy of prematurity because you do not have one of the critical components, right? So what is happening with retinopathy of prematurity? Well, if you were under 32 weeks, what is really going on is that we talked about yesterday in utero that oxygen level is low. It's in the 50, 60 range. And when that oxygen is low, coming through the placenta all the time, that is sending out growth factors for the retina to become vascularized. And as long as that stays in that low oxygen state, those growth factors continue to go and vascularize the periphery of the retina. That's a great system until you're born prematurely, and we give you tons of oxygen because we need to oxygenate your lungs, get the heart moving, make sure the brain is perfused, because now you're not in the uterus anymore. Well, that stops those signals to vascularize the retina. So all of a sudden, you have a partially vascularized retina, which means only where it is vascularized are you going to be able to have a visual field, right? So you are partially blind or have some severe issues with that. So we have to keep your oxygen low enough that you can continue to vascularize the retina, and high enough that your lungs and your brain and your heart and the rest of you continues to perfuse and to continue to grow outside of the uterus, okay? So that's what's going on in this case of retinopathy of prematurity. They have been born early, the vascularization stops because the oxygen raises, and we have to continue to monitor that with ophthalmology and work with those oxygen levels to continue to allow their retina to vascularize. Now, why does this matter to you? You're like, I'm never gonna work in the NICU. Okay, that's fine. Let's say a kid got out of the NICU, they just moved to Fort who knows where, and the family is trying to establish care there with you now that the infant is all better. One of the things that you need to make sure until you know that that retina is fully vascularized is that they are hooked up with ophthalmology as an outpatient, okay? That is why that's important. The other thing, if you've ever been around a baby and you're like, oh, that baby's really creepy looking because I don't know where they're looking. Their eyes are like this way, that way, and all over the place. That is a normal finding for a baby. Baby comes out, and the vision is typically somewhere from 2200 to 2400. If you think about that, that is legally blind. That's like, I see some color, I see some shadow, maybe I see my mom's face while she's feeding me. That's about it, right? They've been in the dark the whole time. So over the course of the next 4 months, their vision is going to go from a 2200, 2400 up to normal vision, or some sort of normal vision, about a 20/60. But while it's in that 2200 stage, right, the eyes are just googly eyes, and that is normal for that baby. So that is why the timing matters. If a question, or if a baby comes in for a 2-month visit, and the parents say, I don't know about this kid, the eyes are all over the place, I don't know where they're looking, your answer is very different than that same family coming in and saying that it's 6 months. If it's 6 months, they're saying, I don't know where the eyes are looking, we're all over the place, that is a call to ophthalmology. Something's not connecting in the brain and sharpening up like it should have. Very different from a 2-monther to a 6-monther, right? So that's why those ages matter. So if they come in and at 4 months, that's still googly eyes, 4 months would be the indication to say, this isn't normal anymore, we at least need to get you checked out with ophthalmology. So dysconjugate gaze, normal up until 4 months. Okay, let's move from the eyes. We're moving down into the ears and the nose. Let's start with the ears. So the ears, if you look at your neighbor, you should be able to see from the edge of the eye down to the back of the occiput. And if you drew a line, or if you put a pencil or a pin there, it should intersect the ear. If it does not intersect the ear, then the ear is a low-set ear. And those low-set ears, though on their own are not diagnostic for anything, are going to have an increased likelihood that there is going to be a genetic something going on, right? So low-set ears is one thing to look at. Now, if your buddy has low-set ears, it is not licensed to be me. No blame. Okay? You're also looking at what is the rotation of the ear. Is the ear in line with the rest of the face and the occipital protuberance, or is the ear rotated anteriorly or posteriorly? Remember, what was, in the case of a physical exam, which way did the ear move for a subgaleal hemorrhage? Anterior, yeah. So knowing what is normal can help you in that case then to say, oh, in this case we have anteriorly or posteriorly rotated ears. The other thing that you can look at is that there are sinus pits and tags of the ear. So if you look again at your buddy's ear, the little, that's one is a pit. So if you look at that, it literally looks like a needle and there was just a little poke in there. Sometimes the pits can just be a pit. Sometimes there can be a sinus tract that can have some sort of leukocytes and pus that will sometimes come out of there that will need some intervention. And then tags. So right by the tragus, there can be little skin tags that come off of that to note. Now, that's interesting, right? You're like, oh, there's a little pit, there's a little tag. Why do I care about that? Do you care about that? Is that just an interesting factoid for us here? Well, yes to both. The reason that you care is that the ears form at the same time embryologically as the kidneys. So if something has gone on and there's some sinus tags or pits, or something is rotated or the ears incorrectly, it makes you think, well, what did the kidneys do then? Was something else going on with the kidneys at that time? Are my kidneys okay? So it just raises that index of suspicion to make sure the function and the anatomy of the kidney is okay. The other thing with the nose, remember this human just came out. You cannot assume that the nose formed correctly or that there are two patent airways there. So one of the things you will do is you will look at the baby, occlude one nostril. Do they turn blue? Nope, because they're obligate nose breathers. They're going to breathe through their nose so they can eat through their mouth. We occluded one. You don't turn blue? Great. Occlude the other one. Do you turn blue? No? Great. If you do, you will pass an NG tube, nasogastric tube. If it gets stuck, like, it didn't pass. It's not patent. The other part of that nasal exam that you're going to look at is partly if there is a cleft lip or a cleft palate. Sometimes the nose and all those surrounding structures can be involved. So if you're looking inside the mouth, which we'll get to next, and you were noticing, well, we don't have a cleft lip, but maybe we have a cleft palate, and that posterior palate, then nasal structures can still be potentially involved. So something to check there. Your ears, everyone take your ear and fold it forward, and it should just snap back if you let it go. That's normal. That's a normal cartilage, right? It shouldn't stay folded. If anyone stays folded, we can just talk about that after class. That's fine. But that's different from a premature infant. So that's one of the, yesterday when we were talking about Ballard scoring and baby yoga, this would be one of the things. If you folded over the ear and it just stayed, that would give you an indication of how premature that baby is, or how much rounding you see. The edge of the ear can give you an indication of how well done were they. So you kind of see it's like a pie. At the end, it just kind of curls over. Once you get down into the mouth, we start looking, so we already talked about cleft lip, cleft palate being a thing. The other thing is I kind of think about the mouth is that all the little extra pieces, have you ever done a house project? You have little extra scrap pieces of wood lying around. This is one area where all those little extra pieces go. So inside the mouth, there's some extra keratin. And so you often will see these little bits of keratin, the cysts that you see that are on the gum or the palate. So you have Epstein pearls or Bond's nodules, depending on their positioning, that over time just get absorbed and go, right? They are no problem. They're literally just extra little keratin pieces, where then the baby realizes, oh, we don't need these anymore, and they just reabsorb. So nothing to worry about, completely benign, but a lot of times the parents will say, what is this little white thing in my kid's mouth? Just a keratin pearl. Now that is different from a natal tooth, and I need to put a picture in here. I had a great baby that we delivered that literally had 2 teeth sticking up. So a little wild when you're like, oh my god, this baby has a tooth. It can be their baby teeth, their primary teeth, or it can be supernumerary teeth. So you can see both. The concern is that these teeth, something happened where they shouldn't have come out so early, so are they really anchored in place? And if they're not anchored in place, does this become a choking hazard? So dental will remove these teeth to prevent that from being a choking hazard for this child. The teeth themselves are not harmless, but the rest of the keratin pearls are harmless, just to make that slide make sense. Moving down into the neck, we're finishing up heat. The neck is going to be something where you're looking at, does this look normal? Are there bulges, bumps, cysts, funny structures? Does something not look right, right? And then you will be describing that using your anatomic terms. So is something midline going on? If there's midline deficits, this is where embryology becomes important again. So the midline, what's in the midline? The thyroid, right? So did something go amiss with the thyroid? Versus, is it lateral to one side or the other? And then when that happens, is it anterior to the sternocleidomastoid or posterior, right? Those will help you differentiate what is on your differential. So this is not the only thing, but for example, an anterior malformation would be more of a brachial cyst versus a posterior to the SCM. You would have more of a lymphatic malformation, like a cystic hygroma. So it just changes your differential based on your anatomical findings. Oh, it says on there, but I'm like, guess what your imaging choice is for this? Ultrasound. You're seeing a pattern here? So on a test, pick ultrasound. You're going down into your chest evaluation. You've already evaluated this a little bit while you were doing your APGAR scoring to see is there chest rise, is there chest fall. So you're looking, is this equal on both sides, or do you have a flail chest going on? Do you have something that's not moving bilaterally? And then for those LGA babies, what did LGA stand for? Large for gestational age, right? So if these are large and in charge babies and they went through the pelvis, a lot of times they'll be so large that to get them out, OBs really literally will cross their arms and crunch their shoulders, and that can result in a clavicle fracture. So you can feel a step off right after birth. This would be considered really the only normal fracture after birth that's not having abuse on your differential because it can go with the birth process. Most of the time, you see it in LGA babies or some sort of shoulder dystocia where the shoulder is stuck under the pelvis. Listening to the heart and lungs, because nobody gets out of a healthcare assessment without having their heart and lungs listened to. This might be an indication where you might hear that murmur from the open ductus arteriosus for a little while, or you might not, depending on how long it's taking to close. Block 3 has a whole lecture on heart murmurs and congenital cardiac. So we're just going to touch on this a little bit. But the other part, and I will probably say this 100 times to the point where you'll be tired of hearing it, is that we often forget that the cardio exam is not just cardio, it is cardiovascular. So that is a system, cardiovascular. So do not forget your vascular exam under that cardiac exam. So not only are you listening to the chest, but you are checking the vascular as well. So for a newborn infant, that means where are you gonna check pulses in a newborn infant? Where? Brachial and fem. Yep. Brachial and femoral, right? Why aren't you checking the radial?
Too small.
It's really, really small. Most of the time you start feeling your own pulse. And the reason, do you know why you're checking the brachial pulse and the femoral pulse together? Yep, coarctation of the aorta. Yep, so you're making sure that blood is equally going to the upper extremities and the lower extremities. So we'll go into all these. Do you have weak pulses? So is there not enough outflow? Do you have bounding pulses? There's too much outflow. Are they equal? Are you hearing a murmur? Are you hearing nothing? How are you describing that murmur? Do you have hepatomegaly and it's telling you there's some sort of fluid overload somewhere or impedance of that venous return? So things to think about. Again, we'll have a whole lecture in block 3. You guys already got this. There's literally, this question is on every PANCE, every board exam for PEDS, everything, and there's only so many ways to ask this question because it's a differential of upper and lower extremity pulses. The lower extremity is going to be weaker, and you see a temperature differentiation that they give you different upper and lower, they give you, their legs get tired, and they have ruddy upper extremities. Like there's only so many ways to ask this, and they're asking for coarc every single time. Okay, so I say this though because this should be something that is caught at the newborn exam, right? We had an 8-year-old that had this, that had it gone unchecked, and the surgeons were really not happy to have an 8-year-old with a coarc that was not caught, because that could have been taken care of at day 8, not 8 years. With this very simple exam for fem and brachial together. Yes, sir?
Is that something you're able to feel by hand or something you need a doctor for?
No, you can feel it. Yeah, you can definitely feel there's a difference differentiation. And then afterwards, then you would be getting a Doppler and echo to look at all the structures. Good question. Okay, so chest wall, moving down into the abdomen, babies' bellies. Do babies have six packs? No. So I call it affectionately the toad belly, right? They should just look like little toads, right? If a baby looks like they have a six pack or really fit and trim, something's wrong, right? Then you start thinking, where are the abdominal contents? Where have they gone? Right? If that's the case, and you have a little baby Hercules, what are you concerned about? Remember, have you guys learned this at all? Your big concern is all of the gut actually up inside the chest when you have a diaphragmatic hernia, right? That would be a concern, right? So you want a baby that looks like a toad. You want toad belly babies. They should be soft. You should not be feeling anything that's a hard mass. You should literally be feeling like you're kneading dough and kneading bread. That's literally how soft baby bellies are. And then you're checking the umbilical cord. So you're seeing, is it a 2-vessel or a 3-vessel cord? Look at that cord here in just a second. So the cord is going to have 2 arteries and 1 vein. So if you remember back to some time where you did fetal anatomy, you have, this is one of those switcheroos, right? Where you have the veins and the arteries doing different things than they would normally do in regular physiology. So the deoxygenated and oxygenated switch in utero. But this is convenient because now you have basically a large vessel that is out and available, if needed, for this neonate right after birth to be used as a central line, right? So some people are using subclavian, some people are using all kinds of things for these large central lines where babies have them built in. So you can put a central line into the umbilical vein. The reason that matters is because anytime you manipulate a large vessel, you are at risk for follow-on hypertension. So you have a baby who you're like, these are brand new vessels. It's like a hair tie, right? Like they're elastic all day long. They shouldn't have any kind of hypertension. Why does this little child have hypertension? Oh, they had a central line placed when they were in the NICU. Oh, that's helpful to know. So that's why we care about these vessels. The other thing that we care about is that there are, with the 2 arteries, there are sometimes 1 artery. And you see that could be a totally incidental normal finding, or that could be another one, much like the ear placement. Hey, is there something genetic going on? We have a single arterial vessel cord. Seen, it correlates then with other genetic anomalies. It's not the causation, it's not anything that, oh my goodness, you have this. Nothing to be up at night about on like a prenatal or anything ultrasound, but something to be aware of. Is as you stack together things, that becomes something to think about. With this, who grew up in the days where you had a younger sibling and your job was to clean the belly button? Anybody have that? There used to be a big thing that pediatricians would say. We need to clean the belly button with alcohol and all kinds of stuff to make sure it stays clean. Do we do that anymore? Based on my questioning. No, why? Think about the physiology of this. The umbilicus is really functionally like a big giant scab, right? So it needs to fall off. So the leukocytes underneath go in and basically remold it, and eventually the umbilicus just falls off. So you want to actively do nothing with the belly button, right? That's what you want to do. If you are continuing cleaning it with alcohol wipes or alcohol, rubbing alcohol or whatever, it's just going to hang around longer because you are killing the cells that are going in and eating away. However, if you've told the parents, actively do nothing with this, don't submerge the baby yet so we know the system is closed, but do nothing with this, and then it doesn't fall off for a long time, that's when your physiology should start to kick in and think, okay, so it's like a scab. It's like the leukocytes should be clearing this off. It's not doing that. What sort of immunodeficiency do I have going on here? You need to start thinking in that realm. Other things that can happen with the umbilicus. Remember, this was what was connecting baby and mom for a long time. So you can have some remnants of things that really, though they're common, are still not normal. In PEDS, I call these your normal abnormals. You see them all the time, so they're common and they're abnormal, but they're kind of normal abnormals. So this would be one of those, the umbilical granuloma. A little bit of redundant tissue left from that connection between the inside and the outside. So it's just this little tiny granuloma. It's the mucosal layer, and so it continues to kind of have a discharge that comes out. Doesn't hurt the baby, doesn't do anything, but it does need to be cauterized. So this would, you would take a silver nitrate stick and just cauterize that little granuloma. Usually takes one treatment and it is done. However, you cannot just assume that it's a granuloma, because what if you have another remnant? It's not just a little bit of the mucosa, but you have a patent urachus, where now you have urine coming out of this, right? You push on the toad belly and urine comes out, you're like, whoa, 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 that's a way different type of connection that I was not prepared for. Or you have a persistent vitelline duct, where you push on it and there's all kinds of discharge coming out. You're like, whoa, 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 I did not sign up for this, right? So in that case, guess what your imaging of choice would be? Ultrasound, yep, to make sure that you are checking to see how aberrant is this connection. Or is this just a granuloma and I can go ahead and cauterize that. So we're moving down then from the abdomen now into the hips. So the hips, and we'll go over this several times. So the hips you were worried about, did they form correctly so that the whole acetabulum of the hip is covered? And that is the biggest thing that we see at birth. Infants spend all 9 months, so they should, in this flexed and adducted position, and so you should have that coverage. However, to be able to move around a little bit in utero, there is some laxity to the hips. So if you've ever seen infants or kind of held them, their hips just are a little wobbly, or their feet, you're like, how can you put this behind your head and do all kinds of crazy hip things? So there is some laxity to every single baby. So that's kind of our given. What we worry about is congenital hip dysplasia, where, hey, this hip didn't actually form, there's not full coverage over that acetabulum. And that's what we really worry about. Because if there's not full coverage over the joint, is this going to dislocate and relocate, or dislocate and stay out? And then we have a big problem. We have a baby with a dislocated hip. So that's what we worry about. The left hip, anecdotally, is more affected than the right, often thought to be the intrauterine positioning of the baby and how they are. The other things that are risk factors. So if you are female, you are significantly more likely to have hip dysplasia than males. The thought is that there's excess estrogen, and so that is going to contribute to the laxity and the hip placement there. Family history, so if all the siblings have this, most likely going to be that as well. And then breech presentation. So this is why I need you guys to star, highlight, underline, highlight, do whatever you do that says this one's important, because breech presentation, the other ones are all risk factors, but the breech presentation is the one that we will do a screen for 100% of the time, right? We are not going to screen every female. We are not going to screen every firstborn child. We're not going to screen everybody that had oligo, didn't have enough fluid, but we are going to screen every single child that was born breech, because you know then that their hip positioning was different. They didn't have the mobility where their head is down to be able to move those hips. They are much more in a fixed position with all that pressure down at the angle of the hip. So the other thing that we see is postnatally. Have you ever seen a little tiny baby that somebody is wearing and they're facing out? We do not want that, right? When the baby is facing out, there is too much external abduction and extension, right? We don't want that in the baby. We want a little bit more flexion and abduction. And so we will say turn the baby around towards the parent so that they are up in a flexed position rather than being out to the world. Swaddling can do that. If you ever see babies that are swaddled like a straitjacket, too tight, that can be another thing that you see with that too. So how are you going to test for this? You're the provider. Your hip exam is going to be with a Barlow and an Ortolani maneuvers. So do you think this is going to be done with the diaper on or off? Off. Perfect. Because the diaper, you should see people, they will like jam these diapers on. It is wild. And that can actually hold the hip in place. So you will take the diaper off, be ready to be peed on, and then you will do this maneuver. So the maneuver itself, you're basically taking your third finger. So if you're going to make Make a gun with your fingers, and then put your third finger out. Your thumb and your third finger are what going to be the two that are on the hip. So you're into your anterior ASIS, and then the posterior hip is what you were holding. So you are holding one hip, and you are pushing straight down with the hip. So that is how you are trying to do the Barlow maneuver to see if you put posterior pressure, does the hip dislocate. Now when you do that, you put this pressure down on the hip, you might hear a little bit of a click, you might feel a little bit of a click, you might feel something, hear something, you're like, ooh, was that a click? If you push down and you hear and feel a clunk that makes your stomach drop, that's not normal, right? Click, okay, we can handle that. Clunk, never normal. Never, never, never normal. So Barlow is, can I dislocate that hip posteriorly? Ortolani maneuver is now you abduct that leg, you use those same fingers, and that third finger now pushes the hip back in. Can I relocate the hip? Right, so if you hear clunk, clunk, bad day. If you hear clunk and you can't get it back, even worse day, right? That's a real, real bad day. This is not, they are specific, but they're not sensitive. So if you hear a clunk, again, bad day, absolutely stop what you're doing, make sure this child gets evaluated. But it's not, it doesn't catch every single hip dysplasia. So that's why it is specific, but not sensitive. So the clicks from that laxity that every baby is going to experience is going to be normal in those first couple weeks. Your clunks, always abnormal. Stop what you're doing, send them to ortho. However, this again is that timing. So they come back for their 3 to 5 day newborn visit and you hear a little bit of a click, totally fine. They're here for their 4-month visit, 6-month visit, and they still have a click, I would do something. That's when you start doing more evaluation. Or they come in and you see their hospital paperwork and you say, oh, you were breech? Okay, we're gonna do a screening for you. And that screening is our typical, what we love, ultrasounding the hip. So you're literally ultrasounding that hip joint of any breech baby, female or male, any breech baby, if you were born prematurely, postmaturely, anybody who's breech gets an ultrasound about 4 to 6 weeks after life. You're like, well, but I have them in clinic, and they're 3 days old. Why don't I do it now? Because they still have that hip laxity, and you really want to catch the ones that are going to be more specific and less sensitive. So those are who you're trying to target. So you're going to trust your exam for those first few times to catch those the big bad ones, and you're going to use your hip ultrasound to catch the more subtle ones at that 4 to 6 week mark. Again, little flow chart of the exact same thing, if that is how you prefer to study of algorithmically who's going to get hip ultrasounds and when. How are we going to treat this then? Well, we want to make sure that that acetabulum can cover that whole hip joint. So certainly ortho is going to be, and PEDS ortho is going to be where you send them. And the coolest part about PEDS is a lot of treatments that we do are really, really non-invasive and they're pretty awesome. So for this, they literally put these kids in what's called a Pavlik harness that keeps their legs in a flexed and abduct position all the time to allow growth over that acetabulum. So it's super cool that we can treat hip dysplasia if we catch it early with a harness. Like, super, super cool. Some surgical options are available, certainly if it's caught late or if it's super severe. And if any of you have grandparents or great-grandparents, before the days of the Pavlik harness, the treatment was, let's pull the knees up and then double diaper, triple diaper them into that position. So they would use this, they would kind of functionally make their own harnesses with extra diapers. So just something to ask, kind of random tidbit there for you. Other things with the extremities. So I learned this the hard way in medical school. Do not be me. Count the fingers and the toes, right? There sometimes can be extra. There sometimes cannot be enough. And you look real dumb if you miss an extra toe or an extra finger, right? Don't be me who missed an extra finger. So count them. There should be 20. The thing that can happen at the top, you have a supernumerary digit that can happen. You have syndactyly, where the webbing is not kind of eaten away in utero. You can have clyndactyly, where the pinky is turned in. You can have all sorts of variations. You want to make sure that there's perfusion, so you're checking the capillary refill. And just a pet peeve, if you haven't ever been with me for any kind of clinical skills, we teach cap refill like this. I don't really know why we do that. The way in PEDS we do it, because their hands are so small, is we go to the back of the hand, we use the thumb, we press, and then you see what happens there, or the middle of the hand. So that's the way you're checking rather than just nail beds, especially for the little guys. Back of the thumb, hold it down, give it a good press for 1, 2, 3 seconds, and then come off and see if it refills. It's a whole lot more clinically valuable than just nail beds in the PEDS world. So you're checking cap refill. Are both hands and feet the same? And then if you see that, are you just, let's see the top one, are you gonna be like, oh, that's just barely attached, I'm just gonna rip that off?
No.
What are you gonna do?
Convert to
I love the person who said ultrasound. You probably could. What other study could you do to check x-ray? What are you looking for with x-ray? Bones. You're gonna see, is there any bone in there? And then you're going to be checking too, with hand to say, is there any vascular structures? So back in the day, we would literally take surgical thread and just tie these off. And we did that. And then people would have paresthesias and some nerve issues as they grew up. So now hand surgery takes all of these for that very reason. But please count them, don't be me. Much like the ears, this is another area of the extremities where you can look to see if they're more preterm or more term. So if you look at the bottom of the feet, the number of creases are going to correlate with how old you were. So the number of creases on the hands and feet, but particularly feet, shows you how much movement is going on in utero. So the longer you were there, the more movement you have, the more creases you have. So a very, very smooth foot, more premature, lots of creases, more term. One of the abnormal findings that people come in for that parents will be very concerned about, that most of the time is a normal finding, is going to be a metatarsus adductus. So if you've ever seen a toddler, so this is basically what people will call a pigeon toed, so they will walk in with their feet like this as they're learning to walk, as I try to break my ankle off the top. And over time, as their legs get stronger, it goes from pigeon toed kind of up and out. That is a normal process. And so if you see a 15-month-old walking and they're just all pigeon toed, totally normal. If you see a 4 or 5-year-old with that, not as normal anymore. The concern is if it persists over time and the feet continue to be rotated inward, what's happening with that knee and hip joint? Is there actually some hip dysplasia and this is a compensatory mechanism? Potentially. So if you have parents that are very concerned about it, you can do a couple of things. Looking at that mid-heel bisector line, put the foot inside of the pinky, or of your the foot goes inside your 2 fingers, and there shouldn't be a large gap, or it should be closing over time. And it should be able to bisect then, so no gap, and then that should be able to bisect between the 2nd and 3rd toe. If you're looking midline, it should be going inward. Most of these will resolve by the time they're 2. So if they come in at 15 months very concerned, you document a good physical exam, and you continue to monitor them. If it's still persisting, there was no hip dysplasia, then at the age of 2, that would be more of an indication to refer. This is very different than if you had something that was fixed at the time of delivery. So metatarsus adductus, you should be able to passively move that foot into a midline or even an extended position. This is very different than talipes equinovarus, or colloquially known as clubfoot. So in this position, they are fixed. So it is inward, but it is a fixed positioning that you cannot passively move to a neutral or an extended position. A lot of times this is unilateral, but in half the cases it still can be bilateral. A lot of times you're worried that it's going to be shortening of that calf muscle, and clearly if they have this fixed, they're not going to be able to walk and have a normal gait. So this is one that you don't wait till they're 2. This is one you send to ortho right at the time of birth, because they are going to do serial casting most of the time. So they will move the foot slightly, cast them there for several weeks. Take the cast off, move the foot slightly more, cast them. Take the cast off, move the foot until it slowly over time stretches that out. If that doesn't work, that's when they will do potentially a tendon transfer or do a tendinotomy to release that. So this would be an indication, ortho right away at time of birth versus based on your exam, ortho when we just, at 2 or we just watch and we expect it to be normal. So that's where your timing matters with pediatrics. Your GU exam, you're going to see what do we have, right? So you have male or female. For males, you're going to ask the family, hey, do you guys want a circumcision? Because it's an elective procedure, so yay or nay. I've seen the incidence of families wanting that elective procedure, and really that's kind of the only elective procedure, maybe ear piercing would be the other one, in children. One of the things on your evaluation would be though, is the urethra in the right place? Right? You can't assume this brand new human has everything in its right positioning. So you're checking then to see, is the urethra at the tip of the penis? If it is not, and it is anywhere down that dorsal surface, then it is considered hypospadias. Ventral surface is epispadias. There we go. You're also going to make sure there's no hernias, where you don't have any of the abdominal contents in the scrotum, or a hydrocele where the scrotum is full of excess fluid. So that's part of your exam for a male GU. For females, some interesting things that will happen. So the labia and all of the surrounding structures will look very hypertrophied. And that is from all of the excess estrogen that mom has on board. And so the infant has been seeing all of this high concentration of estrogen while in utero. And so what you can think about is that this child functionally goes through reverse puberty. So after a couple of weeks, you might open the diaper one day and be like, oh my gosh, there's blood in the diaper. And that's a one-time estrogen withdrawal. So it looks like a little baby period. But if you aren't expecting that, haven't given that anticipatory guidance to the family, and they open up a diaper and see blood, that's a bad day for everybody, right? You just have freaked out families. So the withdrawal from maternal estrogen not only can cause the hypertrophy, but it can also be that withdrawal bleeding. And then you need to make sure that they have an anus, they have the hole, and it is correctly positioned, right? Because they will come out. One of my friends in residency, we got stationed 2 different places. She went off to Japan. The very first day on nursery, the first baby born had an imperforate anus. And so she was like, glad we trained for this, right? Because that was the very first baby. If you don't have a hole that goes all the way through, that's a surgical emergency. Right? So checking to see, do you have that? The back of the infant, make sure is the spine midline. Is it straight? Is it what we think it's going to be? At the bottom, you'll see it could be a gluteal fold, so it's folded funny, or you can't see the bottom of where the spine is going down into that. And so if you are pulling apart the gluteal cleft and you can't see the bottom, you have a pit there, guess what your imaging evaluation is? A spinal ultrasound, correct. Because you are worried, is there an aberrant connection from your CSF, from your spinal canal, out to the surface? Right? So you're looking for a tract there. The other thing that you're worried about, is there a tuft of hair or anything that is blatantly obvious on the outside, which would be concerning for that spina bifida. So again, a little re-hit from yesterday. That is going to be, it's actually, I think it's super cool. So in the embryonic phase, in those first 8 to 9 weeks, basically the baby is 2D. And so in embryology, the 2D baby at some point basically folds in on itself, becomes 3D, and then zips up from the top and the bottom. The thing that makes the zipper go is folate. And so if you don't have folate, you can have anencephaly at the top, and down at the bottom, you end up with spina bifida, right? So that's why you need that folate to close at the bottom. And so that is why then for spina bifida, you are worried, hey, what was those folate levels? What's the rest of this going on? And then how much actually formed at the bottom? How much didn't zip close? So do we have spina bifida occulta, spina bifida, all kinds of various shapes and sizes. So you could, in some cases, have some of the spinal cord that is on the outside. You could see just the tuft of hair. You could see the cleft and a tract that is there. You could see all shapes and sizes of that. I know that You have all kinds of free time your senior semester, but a really cool documentary, if you like those type of things, is a PBS documentary called Born Twice. Super cool. These wild cowboy neurosurgeons were like, I think we can fix this. And so it's like the most controlled surgeries ever. So while mom is pregnant, they go in and try to cut the uterus open. They pull the little hand out. They give the baby anesthesia. Then they pull the butt up. They fix the spina bifida, basically get it all tucked back in, close the baby up, undo it, put them back, close the uterus up, let the baby kind of continue to develop as normal, right? To prevent them having spina bifida occulta on the outside. So if you saw this ultrasound, potentially you have these wild pediatric neurosurgeons that are doing these crazy procedures. Yes?
What happens to the amniotic fluid then? How do you
They don't always, so they will lose some amniotic fluid, but the baby will continue to make it because it is from baby urine, and then that swallow reflex. So yeah, but you'll lose some of it. A super cool documentary. So in all your free time, if you're like, I want more medicine in my life, Twice Born. It's a good one. So if you don't do, yes ma'am.
Just a time check.
Oh, see, I told you, thank you. I got so into this and I'm like telling you, yes, take your 10-minute break. We'll be back to spina bifida. The prevention of that is going to be key unless you want these cowboy neurosurgeons. The prevention again is folate to help with the zipping, quote unquote, of that neural tube. That's a big takeaway there. The other part of your neuro exam when you're doing this for the baby is looking at the primitive reflexes. So the reflexes that you are born with. You are not born with every reflex, but you are born with the primitive reflexes. And typically those will disappear about 4 to 6 months of age. So if they're not disappearing, then you are worried, hey, is there a focal neurologic or brain issue going on or a peripheral nerve lesion? So you have a couple of options. Is it the nerve itself or is it something in the brain? Because I expect these primitive reflexes to go away as you get some of the acquired reflexes. So we're not going to look at all of these, but there's some of these that I do want you to know. So the Moro reflex is what people would consider the startle reflex. So when you see a baby that just looks like they've kind of like that's what the Moro reflex or the startle reflex is. You can help that a lot of times by swaddling them. This is the one that people want to avoid because they're like, oh, my baby's asleep. And then they did the Moro reflex and now they're awake and crying. The grasp reflex, so again, as similar to yesterday, if your mom told you that you were a perfect 10 and I burst that bubble for you, if you have seen the pictures where you have the newborn baby holding on to dad's finger and they're like, he knows me. I'm so sorry to burst your bubble. That's a primitive reflex. Right? So they have a grasp reflex with their hands and they have a grasp reflex with their feet. So you could put a pencil in the hand or on the foot and it would do that as well. The rooting reflex is for feeding. So that is if you touch the corner of the mouth, the head will turn in the direction of which you are stroking. So that is helping to turn the head towards a breast, any kind of nipple for feeding. Let's see, which other ones I want you to know? Oh, the parachute reflex. And so you're seeing on the side, they typically go away between 4 and 6 months. And they come there at birth, so primitive. The parachute reflex is a little different because that's not coming on until about 8 to 10 months. And then it never goes away. So the parachute reflex is one of the funniest things to think about if you thought that you didn't have a parachute reflex. So what happens about 8 to 10 months, for those of you who have had children? What kind of skills are they developing? Starting to crawl, starting to pull up on furniture and standing, right? So what the parachute reflex is when I am falling towards the earth, I put my hands out, right? That is what the parachute reflex is. So it's around the same time that they're learning to stand, and that should never go away, right? So if you think about a world in which we don't have the parachute reflex, it's hilarious. Because people are falling and they're just falling flat on their face. Okay? So that should never go away. The other one, and the difference between children and adults, is the Babinski reflex, right? So you've learned from your other courses, hey, if you have a Babinski reflex where the toes flare backwards, this is a bad day. And here I'm telling you that's totally normal up until about the age of 1. So another difference that you see there. So some of those primitive reflexes. So this is just an example. The Moro reflex, you drop the head back and they startle. The grasp reflex, oh, so cute. Babinski reflex, that rooting or sucking reflexes you will see sometimes. grasp again. And then the fencing one is just kind of interesting. It's really just a tidbit. It's really just the reflex of hand-mind connection and orientation. So what you see is one side is flexed and the other side is extended. And the head turns towards the extended side. So it's really just looking at, do I know which way my hands and feet, and do they coordinate together?
Is that a thing where you turn the head and then the arm extends, or would you extend the hand and foot? And
The
then
head
turn?
usually first. The head goes and then they will go. So what happens when neurologically something happens that goes amiss? So one of the things that can happen is that you have specific nerves that get affected. So we don't use these a ton in OB anymore, but forceps are basically giant claws that will go inside the pelvis, go around the head, and help pull the head out. So it's a toss-up between which ones pediatrics hates more, the forceps or the vacuum where they're pulling the head, giving them subfilar hematomas. In the forceps, because it is so much pressure, you can see that facial nerve gets compressed, and then you have asymmetric crying. So that's, if you see that in a test question or on your pants, asymmetric crying in a newborn, you're concerned that there was a forceps delivery there. A couple of other things that will happen. So we talked about these large babies, the shoulder dystocia, the shoulder is stuck under the pelvis. You can also just have a difficult delivery where there's a lot of pulling and tugging on the head. So the head comes out, but the whole rest of the baby isn't. So there's a lot of tugging and there's a lot of strain on that brachial plexus. And depending on what part of the brachial plexus is stretched will depend on what sort of peripheral nerves are damaged. So if you have the top part of the brachial plexus where C5, C6 are damaged and pulled, you have what's called the Duchenne's palsy. And this one is often called the waiter's tip palsy, and the reason is you stretch that side, now you've lost the biceps reflex, so you babies can't do this then, and so the arm just stays down and in that pronated position. So the baby looks like this, so they look like they're like, hey, give me a tip, but they have the grasp reflex. So no biceps, but yes, grasp. The waiter's tip, Duchenne's. The thing that you have to watch out for in real life for this baby is concern for respiratory. Think back to semester 1. What innervates the diaphragm? C3, 4, 5, oh dear, C5, C6, right? So you can see some phrenic nerve involvement here, and thus some respiratory. So if you're having to differentiate which kind of peripheral nerve is involved here, the question, and in real life, you're thinking, is there respiratory involved? Oh, okay, then it has to be in that C3, 4, 5, and if it's 5, 6, or Duchenne's. This one, PT, a lot of physical therapy and stretching, and it resolves over time. The exact opposite, so now you're at the bottom of the brachial plexus, so still large baby, shoulder dystocia, difficult birth, but now it's the bottom part that gets stretched. So now you're in the T8 or the C8 to T1 region. So now it's the exact opposite. Your biceps reflex is maintained, but now you don't have the grasp. So now you just look like you're a Baylor bear or something, or just like Klumpke's claw is the way I learned it. So Klumpke's palsy, they end up with the Baylor bear claw hands in this baby. The other thing that you will see is a Horner syndrome, where you have an overdoing of the parasympathetic, because T1 is what your facial sympathetic nerves come from. So now, instead of having your diaphragm involved, you have your sympathetics involved. Okay? So that would be the same thing. Same thing with physical therapy, and over time, they're going to resolve. But would know the difference between Duchenne's and Klumpke's. Newborn skin. Newborn skin you're going to assess the whole time. So you're looking at this baby from head to toe the whole time. And this is one area where there's a whole lot of those normal abnormals. Baby skin is kind of weird. So does anyone know what this white chalky stuff is called on the baby? Yeah, it's called vernix. So it's this white chalky material that comes out on the baby from delivery. So there's a whole lot of things. Why does this happen? Don't know. Is it a function of lubrication for the baby? Is it part of the immune system? Is it keratin cells? Is it their dissolved twin? I don't know. Nobody has a great explanation for that, but it's some grossness. It's got some epithelial keratin, squamous cells, all kinds of stuff. Yes, ma'am.
Is that what's nicknamed like the mom cheese?
Yes.
Yeah.
Correct. And so if you might make sure, one of the clinical questions to ask is, has the baby had a bath? Because this is what is on them. And so some people will not want to bathe their baby for days, weeks at a time. So if you're examining this baby, has the baby bathed? Just a question. One of the things that will happen, much like the little withdrawal bleeding from estrogen of a little girl potentially, something to inform the parents is that desquamation, or their baby is going to shed their top layer of skin more than likely. If they've been living in liquid for 9 months, now they come out to this nice arid environment, and after a couple of days, they just start to kind of peel away, like a lizard. Like their top layer just kind of peels away. That is super, super normal. And so a lot of parents will freak out and they're like, my baby's falling apart. The skin is coming off. What is happening? Like, this is normal. Or you can prepare them. Hey, in a couple of days, likely your baby's top layer of skin will start to slough off. And that was their baby skin. They're getting ready for the real world. So normal, abnormal. Mom and dad want to put all kinds of lotion on it? Let them. This is another normal, abnormal. So amelia is another one of these. It's much like the mouth. You have a lot of these little tiny keratin occlusion in the tiny little pores. So it looks literally like if you looked at the nose, every single pore is full of a teeny tiny bit of keratin. Totally normal, totally resolves on its own, nothing you need to do about it, but parents will ask, what are these little white heads all over their nose? So it's called amelia, resolves on its own, nothing you need to do. Another normal, abnormal, and you will see this a lot in San Antonio, especially, or anywhere if you do your rotations where it's hot, is called Melia rubria. So this one is kind of, on the layperson term, known as a heat rash. So adults and older children will get this as well. So you'll see this erythematous, raised, small little papules. And the way that you can say that, hey, this is a heat rash compared to like a folliculitis, is that this is not in the individual hair follicles. So it's not follicular in nature. It's got this kind of splotchy, non-follicular erythematous papules that are all over. You'll see a lot of families where they're really concerned that the baby's going to get too cold, and so it'll be like July here in San Antonio, and the baby's in like 17 onesies, and then I don't know what this rash is, and you're like, baby's hot. That's what's going on. That is Melia rubra. So usually cooling off the baby will help, or cooling off the child, or even the adult will help this kind of splotchy red rash go away. You see this in teenagers, you see this in young adults who have been outside working out as well. So if they come in after PT and they're like, what is this? And like, heat rash, just cool them off. The opposite is true as well. So they can get too cold. So you can have cutis marmorata, or modeling. So if they look modeled, but the baby is healthy, happy, doing well, either they're trying to die, which is probably not the case, or they're just cold. Okay, so you see this lacy rash. It literally looks like the old kind of lace doilies that grandmas used to make. If that pattern was on their extremities or even on the trunk, that is what this looked like. Again, if you warm them up, totally normal, nothing to worry about. If it persists, if you're like, this baby's warm, this baby's fed, this baby is everything good to go, and you start going down the rest of the differential. And as we talked about yesterday, you will see it in most differentials. Hypothyroid is going to be one of those things. So is there something wrong with the vessels, malformation, hypothyroid, or are they cold? There are big differentials there. This is one of the most interesting ones to me, also a normal, abnormal, but if you have, you'll see it written both ways. Dermal melanocytosis is one way, or slate gray nevi. It used to be called Mongolian spots, so if you ever hear that terminology, this is what they're referring to. But newer terminology is dermal melanocytosis. Super cool embryologically as well. So you have all of these skin cells. So these melanocytes, think way back into anatomy, melanocytes are supposed to go into the basal layer of the epidermis, and that's then where all their pigment is released. These are lazy melanocytes functionally, and so the melanocytes only went to the dermis, and they stopped in the dermis. So they're wrongly placed melanocytes that are giving off pigment in the dermal layer rather than the epidermal layer. And so it comes across in this kind of dark black slate gray looking, and it looks almost like a bruise, and it is not a bruise. And so if you see this, this is important when they come out, these young babies, important to document from the beginning, because if you have a provider who maybe doesn't see pediatrics as much, or didn't have this rousing lecture to explain dermal melanocytosis, you might not be as familiar with that. And so it can be really helpful to say, hey, this is the exact same thing that was documented at their new board exam, much less concerning for child abuse. You see this typically in cultures that have a little bit more pigment. So in children that are Black, and children that are Asian, Indian Americans, Hispanics, any kind of Latin cultures, you see this a whole lot more, just because they have more melanocytes. Cafe au lait macules, these are what we would term as birthmarks. So if you have a birthmark in a child, you will now call that a cafe au lait macule. That is what that is. So these are sharply defined, so it's not running anywhere in the skin where you're like, where is that? Is that slightly differentiated? It's a specific, people will be like, my birthmark's the shape of Ohio. And you're like, okay. That's what that is. And we'll talk about this again when we get to PEDS neuro. But if you start seeing a whole bunch of this, much like the ears and the kidneys that went together, you start seeing that the skin and brain will go together as well too. And so if you start seeing numerous and large birthmarks on a child, you start thinking, do we have other disorders going on? So documenting the size and the number of these is going to be important. Things like neurofibromatosis, tuberous sclerosis, McEwen-Albright, different syndromes like that. And then there's some of our favorites. So I actually should probably change this wording, so I'll give you the word that I want to change it to, but a nevus simplex is a capillary, rather than a malformation, it's really a capillary prominence. These capillaries are just really prominent. They're not malformed, they're just prominent. That's the best word I have come up with. So if you've ever seen a baby that has those little stork bites on the nape of the neck, or has the angel kisses over the eyes, or has the little red marks kind of on the forehead, nothing is wrong with those capillaries, they're just pretty prominent. So anytime you have increase in the vasculature from crying, from straining because they're trying to poop, anything like that, those capillaries are just very prominent and you see that. So those kind of birthmarks that you see, over time, the body realizes, oh yeah, we don't need to be as prominent here, and they kind of back off. So this is an example. This is the same child, 3 months and then 3.5 years old, and the prominence is completely gone. So that is different. A nevus simplex, or salmon patch, very different and normal compared to a nevus flameus. So in this instance, it is a true capillary malformation. The capillaries are formed incorrectly and at a much deeper level. And the reason that we care about this, number one, it's cosmetic, but number two is if I have that on the face and over the eye, or over the, particularly with the eye, I worry that are the capillaries in and for the eye malformed as well? And is this child at risk for things like glaucoma because my vasculature is malformed? Right? So this would be one, if you see a port wine stain, so what a port wine is a very dark red wine, so it literally got its name from looking like you had a port wine spilled all over the baby's face and it stained it. If you see a true port wine stain like this and the eye is involved, they need to ASAP go to ophthalmology. That would be a no miss because you were worried, is there going to be infantile glaucoma? Not just ophthalmology, because cosmetic and these malformations are a real concern as well. So you were worried for that, and they end up at dermatology as well for some pulsed dye therapy and some other dermatologic interventions. And the favorite is erythema toxicum neonatorum. So it has the most scary sounding name out there, and it is the most benign thing in the whole world. So you might hear it affectionately termed as ETOX. They're saying ETOX is erythema toxicum neonatorum. Totally normal newborn rash, quote unquote. So you just see it pop up. It's It's literally, we have no idea. There's a little eosinophilia inside the little rash that pops up. Kind of these maculopapular erythematous base. By the time you're looking at this baby and you're like, that's so weird, I don't know what that is. You go get your attending, you come back and it's totally gone, and you're like, I swear it was just here. That's etox. And you tell the family this is a normal newborn rash. Because you go in there and you tell this mom, oh, no big deal, it's erythema toxicum neonatorum. Now they're gonna freak out. Okay? This normal newborn rash, you don't do anything about it. Documented. A little bit different than neonatal acne. So this is another one, much like that hypertrophy of the female genitalia. When you have that withdrawal from estrogen, it's like puberty in reverse. So they have that little bit of acne that they get, and then you will see in this infantile acne the same distribution that you see as a teenager, from the hormone withdrawal as opposed to the initiation of hormones. So same type of physiology, just in reverse. This one will also be self-limited because they won't have the continuation of the hormones present. But one of the things that you can see and you could consider, again, my favorite word, consider, is that they might want a little bit of steroids over that area because a lot of families will come and like, we have newborn pictures tomorrow or in 3 days. Like, please give us something because we have newborn pictures. Something to consider, but certainly not needed because it will resolve on its own. It might just take a few weeks. Okay, let's do a quick check. At what age do those primitive reflexes, meaning you are born with them, typically fade? Yep, 4 to 6 months. And if they persist or they're asymmetric, what are the two possibilities? What's gone wrong? Something in the brain or some sort of peripheral nerve function. Yep. Awesome. You are one lecture done with PEDS. We are going to jump into that second lecture, so pull that up and bear with me as I pull it up.